from the literature, from the observations of physicians over the past 3 decades, that we see less irritant diaper dermatitis than we used to. And that irritant diaper dermatitis that we do see is quite different from what was the traditional patterns. Now, I know not all of you in the room are pediatric dermatologists, so I want to assure you that this is not just for infants. Because, of course, elderly adults, incontinent adults also use diapers and have the same issues in irritancy. So I put these 2 examples in to just show you that you can think about these things in your elderly patients as well as other patients with developmental disabilities who are not able to control their bowel and urine. Well, in addition to the lowering of the incidence of irritant diaper dermatitis, there are actually some other ancillary benefits of disposable diapers, and these have been shown both in the intensive care nurseries as well as in daycare. A recent study of sepsis or probable sepsis in neonates in ICU showed that the risk of sepsis was higher, or probable sepsis in the cloth diaper group versus the disposable diaper group. And the reason for that probably is the fact that one has less superficial skin injury with disposable diapers. So this may be a strategy to be used in some nurseries, particularly if the rates of sepsis are relatively high. Studies have also shown less fecal contamination of the environment with disposable diapers in the daycare setting. And this is important, obviously, to diminish communicable diseases, particularly if there are epidemics going on in any of the environments. It may also diminish antibiotic use. Well, but there are some problems with disposable diapers, and the environmental burden is absolutely one of these. There are pros and cons to the story. It's not so simple as just that it's all the waste produced by disposable diapers, because you have to consider, for example, in California now, we have a terrible water situation. We may want to encourage people to use disposable diapers so that they don't wash diapers and use more water. So there's an energy consumption aspect to using cloth diapers, but nonetheless, I think most people are quite concerned about the environmental burden of this being a problem, and probably rightfully so. We also have concerns about contact dermatitis. And Margarita Laraldi and others described this finding of the so-called lucky hook dermatitis, which began to develop when the diaper manufacturers introduced elastic components into the disposable diapers to make them fit better, so that you had less leakage. And this led to this kind of morphology along the sides of the hip, which was likened to someone holding a holster and a gun, and therefore called Lucky Luke. Also, the blue and green dyes that were introduced just to make these more colorful and interesting to families as a marketing ploy ended up causing dermatitis due to some of the dyes. But because this is such a big moneymaker for the companies that make these diapers, when these are discovered, the diaper manufacturers very rapidly transition and move away from the components that are causing dermatitis. And so this doesn't end up typically being a major issue in most babies who are using disposable diapers. Well, if we look at a clinical classification of diaper rashes, the one that I've always found most useful is this: eruptions that are due to the diaper being on the baby. In other words, the baby would never have gotten this rash if it weren't for the diaper there. The eruptions that are exacerbated by the presence of the diaper. Examples of this would include candida, albicans infection, psoriasis, things where they might have gotten a problem anyway, but it's much more likely to occur with a diaper. And then there are rashes that are seen irrespective of whether a diaper is present, such as zinc deficiency, Langerhans cell histiocytosis. And this last group, I'm not going to be talking about at all in the rest of this talk. If we were going to do a standard diaper rash talk, probably those would be very important. The classic morphology of irritant diaper dermatitis that I learned about in my training in the 1980s emphasized the accentuation at the edge of the diaper with sparing of the inguinal folds. So anywhere the diaper touched would be, excuse me, I would prefer if you didn't take photographs during the lecture. Any anywhere where the diaper touched, there would be the accentuation of the rash. And that is the very classic appearance of irritant diaper dermatitis. This is another example of that in another child. So on the buttocks, you see again what's sometimes called the tide watermark, where the diaper is at maximum attachment to the skin. And here you can see the accentuation here with the sparing and folds. In contrast, now that we have disposable diapers that lick away moisture extremely efficiently, we don't see that morphology almost ever. And instead, when we do see diaper rashes that are irritant diaper rashes, they tend to be in the context of people having frequent stools, diarrhea, and this kind of pattern is what we see, where the perianal skin is maximally involved, and you sort of have the kissing lesions where the feces concentrate in that gluteal fold right in there. So this is a not infrequent finding, much less common, but not the classic irritant diaper dermatitis that we once saw. Now, you will see this kind of rash in children who are using cloth diapers. So if you see this, you should certainly ask what type of diapers the family is using. This is another example. Again, these kind of kissing lesions, so there's often some symmetry to this, and often very superficial little erosions. Now, this is another child, an example of a child who has a severe irritant diaper dermatitis, in this case due to explosive diarrhea, which is clearly spreading to a larger area. And so if the diaper is not changed very quickly, one can see these kinds of changes due to irritation from the fecal material. One of the things that we know about diaper rashes is that even very young children can get them. And again, those tend to look at more like very focal linear erosions when we do see it, such as we see right here. And this is a child who had chronic diarrhea, and you can again see the irritation developing. And these kind of small round areas, which we see very frequently in children who have irritant diaper dermatitis. And this is another example of that. And when the body tries to heal these, you will often get a heaped up, rather almost verrucous-looking aspect to these. I've always assumed that these were due to just fecal material concentrating in localized areas of skin, although I don't know that that's true for sure, but it always struck me. But of course, the differential diagnosis of something like this is going to include bacterial or viral infections such as herpes. Now, these are children where we see very severe irritant diaper dermatitis, and both of these have anatomic abnormalities. This child had an imperforate anus that was repaired with constant leaking in this area. This child has a ureterostomy, constant urine leaking into this area. And notice that when I pointed out to you those little shallow erosions that became very heaped up, these have now become full-form papules, in some cases very verrucous-looking papules. And so this condition and this is another example of that, again with a child with very abnormal genital anatomy with leaking of chronic leaking of urine from this ostomy site, with tremendous papules with this verrucous look to them. And this condition has been called pseudoverrucous papules and nodules. Those of you who are older like me and learned about granuloma luteal infantum, or Jacquet's dermatitis, I tend to be a lumper when it comes to these entities, and I put them all together under pseudoverrucous papules and nodules, and don't really separate out this condition because I'm not sure exactly what it is anymore, but this is a papulonodular eruption due to chronic irritation, usually with severe chronic fecal or urinary exposure. It's quite difficult to treat. This is an infant with Hirschsprung's disease who the surgeons went back and did a takedown of the colostomy that they had originally performed, and unfortunately a lot of leakage ensued, and this is a really nice example of why these are called pseudoverrucous papules and nodules. So how do we manage severe irritant dermatitis? Well, when possible, we must try to address the underlying cause of this chronic exposure to liquid stool, and that is obviously the absolute most important management strategy. frequent diaper changes, use of disposable diapers that are super absorbent rather than cloth diapers is advisable in this setting. Barrier paste with zinc oxide is important. And a small tip for managing this, when you use thick amounts of zinc oxide and then it gets fecal material soiled all over it, is to use mineral oil to remove the zinc oxide paste, which is much easier than trying to scrape it off with pressure. And it dissolves with mineral oil. And then I frequently add an anti-yeast medication because there is studies that show that Candida comes in as a secondary opportunist in the setting of chronic irritant dermatitis. Well, there's some other important diagnoses that I did want to mention, and those are in that group too, which is they could occur even if you didn't have a diaper, but they're definitely made worse by the diaper. And these include Candida diaper dermatitis, the so-called psoriasiform IB reaction, seborrheic diaper dermatitis, and psoriasis. So classic Candida diaper dermatitis is one like this, which is the beefy red color, the satellite papules and pustules with these little collarettes of scale that you're seeing here. It's very interesting to me, though, that we do not see such florid Candida diaper dermatitis anymore. And again, I think that this is because we have better diaper technologies used by so many families. So this is a picture from many, many years ago. This is not something that I see very often in my own practice. And I'd be interested offline in hearing from some of you who work in other settings other than the United States. It's obvious that this can involve and does involve the scrotum. And again, this involvement of the inguinal folds, unlike irritant diaper dermatitis, and the satellite lesions and the color are the clues to this diagnosis. This Candida albicans is one of those things you can see in newborns. It can occur at any age. We don't usually see severe irritant diaper dermatitis other than those little erosions I told you about in the newborn period. Previous antibiotics increase the risk. There's a characteristic morphology, as I mentioned. And this is an interesting example of one of the more subtle forms of Candida albicans infection that I see now. And in this case, you're not seeing the widespread involvement, but more just a subtle involvement in the folds with a few scattered satellites. So for me, this would be a child that I'm undressing to examine, and it turns out they had a history of thrush. This is the type of Candida dermatitis that we see. I think it's important when you're thinking about treating Candida to realize that, at least in other settings, Candida albicans has developed resistance. And these were actually swabs. This is a study just published last year from oral and diaper samples. This was done in Iran. And they did antifungal susceptibilities of Candida albicans to a variety of different imidazoles as well as to nystatin. And they found that with the various imidazoles, there's a fairly high incidence of resistance, particularly to fluconazole, ketoconazole, etc., with the lowest resistance being to nystatin at 40%. So I think this is worth considering, and I've always really liked nystatin ointment because it's the only ointment available for treating yeast in the diaper area, and I think it's better to use an ointment as a barrier. And so in terms of managing Candida, this is something I always remind my residents of, that is look in the mouth to see if the child still has thrush. Don't just assume, and do a good exam on any child you see with diaper dermatitis to make sure that you're not dealing with something else. Initial treatment would be with either nystatin or an imidazole cream, but not the allylamines, not the terbinafine cream, because the allylamines don't treat Candida albicans infection, so they should be avoided. Consider oral treatment with either nystatin solution, or we will tend to use oral fluconazole if the rash rapidly reoccurs, but also consider the immunodeficiency if it rapidly reoccurs. And I like to add a little hydrocortisone, 0.5 to 1%. I think it clears up the rash a little bit faster if we do that. But there's no evidence to do that. It's more just my own opinion. So moving on, what used to be a relatively common finding and now has become increasingly rare is the child with severe Candida dermatitis, typically, who you start to treat, and then you get the whole call from the parents. This rash is getting worse and it's spreading. So this is probably started, although I didn't see